So my study was about older patients who underwent treatment with a so-called CAR T-cell therapy for relapsed lymphoma. We know that generally speaking, the results of this specific treatment above all ages are good, providing at least for a part of the patients even the chance to be cured, even in a setting of the relapsed situation of aggressive lymphoma. But we know that there are special considerations, especially regarding toxicity for this treatment in the older population setting. And our study was to see if given a prophylactic treatment that is especially used when the side effect as ICANS or CRS occur, if we give this in a prophylactic setting, if this can reduce the toxicity during the course of CAR T-cell treatment, especially in older patients. The study design was that we retrospectively analyzed a patient that received the prophylactic tocilizumab before the CAR T-cell treatment and compared that of a group of patients that have not received this kind of prophylactic treatment. So the results were, given that it's a small number of patients, which I think somehow reflects that CAR T-cell is still not so often used in the older populations, that we saw in a combined endpoint that included the use of steroids, the length of the hospitalization, the need for intensive care unit treatment, and the need of special care after the patients left the hospital significantly differed between the two groups, so that we consider that this kind of treatment could probably reduce the toxicity for older patients who receive CAR T-cell treatment. Well, I think the clinical significance, there are several things to talk about. So one is that we definitely need more data, especially for the older patients regarding CAR T-cell treatment to enable them to get this kind of treatment. We think that, one treatment with this EL6 antibody tocilizumab is a very cost-effective measurement if we can avoid the need for ICU treatment, the number of really significant toxicities. So we think that this could really something that could help older patients to get better through this treatment. And by saying that, motivate the treating physicians to consider even older patients for this kind of treatment. Next is that we will try to analyze a larger group of patients to make our results more significant. And another thing that we will now test together with another university hospital here in Switzerland is if we can do a special evaluation of older patients with something which is called a pragmatic geriatric assessment. This can help us to see if this can predict several toxicities for patients that will undergo cellular therapies. I think while working on that, there are two things important to me. So the first thing is that we need really to be clear or try to define better which older patients qualify for a CAR T-cell treatment, which is still an intensive treatment, and that I don't think that only the gut feeling of the treating physician is the right measurement, that we should really look deeper if there are, like the geriatric assessment, things that can help us to get a better picture of the patients. And even more, so we added as one endpoint how patients were still independent in their daily living after this treatment, or if there was any need that they need to be treated afterwards in a care unit facility. And I think these are endpoints that matters more to older patients, and that should be included in studies that include older patients more.